Good morning, everyone. Today, we will be discussing about a topic that affects a large number of patients, yet often goes unrecognized. That is, non-carious cervical lesion. So, what are these lesions? Non-carious cervical lesion represents the loss of enamel, dentin, or cementum in the cervical third of a tooth, that is, near the gum line. Unlike the dental caries, these lesions aren't caused by bacteria. Instead, they result from the physical forces, chemical erosion, or a combination of both. They can lead to dentin hypersensitivity, aesthetic concerns, clog retention, and challenges when restoration are being placed. If left untreated, they may also deepen and weaken the tooth structure. So, how common they are? The prevalence varies widely from about 5 to 85% in different populations. They are most frequently seen in middle-aged and older adults, and the teeth often most affected are premolars and canines. Factors such as diet, oral hygiene practices, and even the occupational exposures influence their occurrence. Moving on to the attrition, it is nothing but the physiologic wearing of the teeth structure resulting from the tooth-to-tooth contact as in mastication. It occurs at the incisal or the occlusal surfaces, sometimes also on the proximal surface. The first manifestation of attrition is small, polished spaces on a cusp tip or a ridge or an incisal ledge. Attrition can be hastened by a hard and an abrasive diet or silica particles in tobacco or inorganic components in the snuff or some parafunctional habits like bruxism and clenching. At times, severe occlusal wear can cause the amalgam or any other restoration to appear protruded. Sometimes even a caries can superimpose it. So now let's talk about the cervical lesions. They are classified as carious or non-carious cervical lesions. They are non-carious cervical lesions are further classified as abrasion, abstraction, and erosion lesions. Moving on to the classification, the non-carious cervical lesion can be grouped according to its etiology. They are classified as abrasion, which occurs mainly from the mechanical wear like aggressive tooth brushing with a hard bristles, abrasive toothpaste, or habits such as using toothpaste. Whereas the erosion is chemical in nature, which is caused by acids either from the diet or like soft drinks or intrinsic sources like gastric reflux. These lesions often look smooth and glossy. Coming to the abstraction, it happens due to the stress and the flexure at the cervical region. Excessive occlusal forces, especially in bruxers, can create a wedge-shaped defect. And finally, attrition, which is nothing but a tooth-to-tooth wear. Morphologically, these lesions may appear wedge-shaped, saucer-shaped, or irregular depending on the interplay of these factors. Coming to the abrasion in detail, it is nothing but a wearing away of the tooth substance because of grinding, rubbing, or scraping caused by the external mechanical means like in repeated contact of the teeth with the foreign objects or substances in it. Commonly, it affects the canines and the premolars. The most common cause can be faulty oral hygiene practices, the quality of the toothbrush that is used, and the use of tooth powder or ill-fitting clasp of the dentures. And the lesions may show varying grades on depth based on shallow, deep, or pulpal exposure. Coming to the erosion, these defects arise because of the dissolution of the tooth structure subsequent to the chemical attack of either endogenous or exogenous origin or a combination of chemico-mechanical attack. And these appear glazed with no demarcation from the adjacent surfaces, smooth, hard, and polished. Coming to the abstraction, they are wedge-shaped cervical defects which are caused by excessive occlusal stresses or parafunctional habits leading to the loss of tooth structure from flexure and the fatigue of enamel or dentin away from the loading site. So, you may have noticed that most of these lesions occur on the facial surface. Why is that? It comes down to the difference in the bone thickness and the way the forces are transmitted across the tooth. The facial surfaces often experience more damaging tensile stresses compared to the lingual side, making the facial sides more susceptible for these lesions. So, how do we diagnose the non-carious cervical lesion? A thorough history is key. Looking into the dietary habits, brushing techniques, parafunctional activities like bruxism, and any other systemic conditions such as GERD or eating disorders. Clinical examination then helps to confirm the nature and extent of the lesion. Now let's look into the management. And it involves two phases, that is preventive and restorative management. In the preventive management, the first step is to address the cause. This might include switching to a soft bristle toothbrush, correcting the faulty brushing techniques, reducing the acidic food and drinking intake, managing the gastric reflex, or correcting the occlusal disharmony. For a patient with parafunctional habits, orthodontic appliances or an occlusal guard may be needed. Even simple steps like using a less abrasive toothpaste or a topical fluoride can help. Coming to the restorative management part, when the lesions compromise the aesthetic, function, or the patient comfort, a restoration is required. The options include glass ionomer particularly a resin-modified GIC, offers a fluoride release and good adhesion to these lesions. And when a composite resin is chose, especially a microfill composite or the ones opted, as it provides the aesthetics and it can flex along with the tooth. Different cavity designs such as conventional, bevel, or a modified class 5 preparation is used for composite based on the size and location of the lesion. And in severe cases where the pulp is involved, root canal therapy followed by the full coverage restoration may be necessary. And when associated with the gingival recession, periodontal surgery such as graft or a coronally advanced flap may be indicated. To wrap up, non-carious cervical lesions are multifactorial and they demand a careful individualized approach. By combining preventive measures with the appropriate restorative techniques, we can protect the tooth structure, relieve sensitivity, and restore both function and aesthetics of a patient. Thank you.